these deformities of the nose, which are congenital deformities, like external nose, like a bifid nose and all, they comes into congenital categories, which we are not going to discuss today. Today we would like to discuss about. Sorry, hello, just అలాగే అలాగే. So, acquired disease of the external nose. We are going to discuss about external nose diseases and its complications. Deformities of the nose, stenosis of the anterior nose cineris, furunclosis of the nose, inflammatory causes. Anywhere, any diseases, you must divide into things like congenital causes, traumatic causes, and inflammatory causes, and miscellaneous causes in that way. So in that way, the inflammatory causes are furunclosis of the nose, vestibulitis. The complications of the inflammatory disease of the external nose leads to cavernous sinus thrombophlebitis and rhinophyma. This is also one sort of inflammatory, but not typical of inflammatory, but it is somewhat like proliferating type of external sweat glands over the nose, that is rhinophyma, and injuries of the nose, I told you, and complications of the injuries of the nose leads to CSF rhinorrhea. So this is how we divide the various diseases of the nose. Now let's go to the in detail of the deformities of the nose. Deviation of the nose, dorsum is straight, nose is deviated to one side. Crooked nose, these are two types. Deviation of the nose, dorsum is straight, a nose is deviated to one side, whole nose itself is deviated to one side. Crooked nose, dorsum of the nose is bent in a C-shaped or S-shaped, which is maybe due to previous injury or something like that. Etiology, it's due to trauma. Treatment, definitely it is due to surgical correction of this thing by means of septoplasty or rhinoplasty. See, the deviation of the nose, dorsum is straight, but the total nose is deviated to one side. This might happen in a whole total deviation of the septum itself also. So if you correct the septum, your nose may also get corrected. As goes the septum, as goes the nose. So that is one kind of entity which usually occurs below 16 years of the individual. Once the septum is being corrected, obviously the nose also will be gets corrected. But once the patient's facial skeleton age of the growth is totally over, like around 18 years or 19 years, I don't think by mere doing septoplasty in the first deviated nose type of settings, by mere doing septal correction, I don't think you will be able to do that. Total deviation of the nose, total nose itself can be corrected. So in that case, we have to go for the both septoplasty or septal correction, or with the external nose correction, that is with septorhinoplasty. So you prefer when a patient comes to you between 11-12 years with a total nose deviation, but whereas the nose is being straight, you can attempt for a septoplasty and wait for till 19-20 years of age, where you can see the nose is also going towards the septum as in the midline. So you can avoid a rhinoplasty. You can avoid a rhinoplasty at that age. Whereas in crooked nose, whatever the age, you have to go for a septorhinoplasty. It's your option and discussion between patient and you to go for whether to go for a septorhinoplasty in the early stage. As you all know that some amount of complications will be there if you manipulate more in the earlier age of the where the facial skeleton growth is completed. So I personally would like to go for any nose operation, would like to go for a only after 18 years of age. So this crooked nose should be corrected only with both septorhinoplasty after the age of somewhere like 18-20 years. Okay. Stenosis of the anterior iris. This is happens due to trauma or inflammatory reasons, or post-smallpox and rhinosclerosis or rhinoscleroma. Trauma may be accidental or surgical. Accidental is by means of injury to the external cartilages of the tip of the nose. like traumatic accidents are due to chronic trauma due to allergic rhinitis, where you will be constantly picking the nose. Even in that case, also you might get this thing. Whereas surgical, when you do a Young's operation, for the what is that correction of, for the treatment of what is that atopic rhinitis. Not only Young's operation, in some cases where we do like a modified Denker's procedure for nasopharyngeal angiofibroma, where you do a endoscopic nasal uh, removal of the angiofibroma, where we will remove the frontal process of the maxilla, where there is a collapse of the this thing ala, where you might injure some amount of cartilaginous portion of the lower lateral cartilaginous portion of the nose, which might lead to stenosis of the anterinaris. And the inflammatory lesions, as I told you, destruction of the skin and cartilage, that is fibrosis. Inflammatory lesion, any inflammatory lesion at the anterior part of the iris. And post smallpox will also lead to rhinoscleroma. Rhinoscleroma is a destructive disease, benign destructive disease, which might turn into malignancy at a later date in the nasal cavity, which might causes the destruction of the whole nasal mucosa and cartilage and its bones. Finally leads to construction of the external nasal aperture, leads to anterior stenosis. It's a reconstructive disease, and plastic surgical procedures, various plastic tip correction, vestibular correction, and various augmentation with rib cartilage, augmentation with uh, uh, nasal septal cartilage. There are so many procedures are there. I don't think in detail you require, but the nasal stenosis of the anterior correction is relatively 100% correction will be pure and long term poor, and long term results. I don't think you'll be having a very dynamic, good, constant long term results for the anterior structures or stenosis. This is one kind of thing, furunclosis of the nose, and in this inflammatory lesions of the nose, which leads to structure of the anterinaris. Chronic allergic rhinitis also will leads to some amount of closure of the nasal cavities in the external auditory canal, in the anterinaris, where due to inflammation of the cartilage due to chronic allergic rhinitis or due to constant irritation, the nose patients will be keep on constantly rubbing the anterior end of the distal end of the nose, which leads to that thickening of the cartilage. Fibrosis of the cartilage might lead to some kind of closure, which is difficult to correct compared to that of the other traumatic and other post-operative conditions. That is one point to be carried out. Furunclosis of the nose. Furuncle, as you know, that all nose tip of the nose is mostly consisting of sweat glands, and vestibule of the nose is consisting of the hair follicles. And these hair follicles will have staphylococcal infections. Can easily get a staphylococcal infection. The only concern of that furunclosis of the nose PR is its dangerous area of the face. You know, the dangerous area of the face is lower half of the tip of the nose and lateral cartilaginous portions of the nose along with the upper lip region. Why this is all called, this transpire directly into the cavernous sinus through various veins, that is inferior orbital vein and ophthalmic vein, and ultimately leads into cavernous sinus, which leads to cavernous sinus thrombophlebitis, which is a life endangering situation, life grave situation. So this has to be considered a bit seriously and treated a bit seriously, especially in immunocompromised patients like chronic diabetic and HIV and other immunocompromised patients. Trauma, usually due to nose picking, causes are nose picking, plucking of the nasal vibrissae, removing of the nasal vibrissae. We all have a habit of taking out the nasal vibrissae which comes out of the nasal valve, nasal anterinaris opening, which is a very bad habit. And diabetes, important predisposing factor is diabetes. Clinical features, severe pain, as the cartilage is very unlike anywhere. The skin over the cartilage here is unlike anywhere in the body, only over the external aortic canal and external ear, and whereas this vestibule is also very tightly adherent, so that even minimal accumulation of the fluid in between the skin and the underlying cartilage leads to severe stretching. Like even any hair follicle minimum infection also will leads to severe stretching, will cause severe pain. The constitutional symptoms like fever and all, the rubber, collar and all will be there. Starts as a furuncle, leads to cellulitis of the nose. Yeah, that's it. In a number of compromised patient, this situation is very worst. We have seen many number of this kind of patients. Just simple furunculosis leads to being pricked by means, either it starts by means of picking up the nose, or by some other reason it starts with a secondary infection of picking up the nose, removing of its crust and all will lead to cellulitis of the nose. Again, we can see the induration of the nose and furuncle in the nasal vestibule, of course. That is the findings. Investigations, blood exams, tour of the diabetes and fundus examination, spread of infection is suspected. Yeah, cavernous sinus thrombosis is being suspected when there is a changes of fundus the, uh, of the eye. So that's how we investigate treatment. The treatment modality is like anywhere. Hot fermentation is one good reason to make it rupture, like anywhere over the eye region, like chalazion and all. You'll get anywhere when there is a small localized uh, inflammation, like furunculosis. You constantly apply hot applications, it will lead to burst up. But once that it is complicating, like getting into cellulitis of the nose. The hot applications or hot fermentations are more dangerous. Antibiotics, usually broad spectrum antibiotic, got positive, gram negative, and what is that? Metrozil and all should be given. Anti-inflammatory agents like paracetamol and all, depending on the doses, depending on the child weight and all, you have to go cold compressions when it is leading to facial cellulitis. You have to go for cold compressions. Personal hygiene, avoid incision and drainage. Usually they say avoid incision and drainage, but recent theories, whenever there is a furuncle pointing out, you should incise and drain in a aseptic conditions. You take him to the theater, clean the nose completely with a betadine gauze, and under sterile conditions, you have to do a IND. Any recent things they are saying, but some people still they say that IND should be avoided and చెప్తుంటారు. But I don't know how far it's a decision to be taken between the like experience, taken by experience. Complications of this cellulitis of the face, septal abscess, cavernous sinus thrombophlebitis. Just the infection spreads to the subcutaneous tissues of this face and subcutaneous tissue of the septum, that is submucosal tissue of the septum. And you know that dangerous area of the face, the venous drainage drains into the anterofacial vein, through which angular veins of the this thing, from there it goes into the ophthalmic vein, from there it drains into the cavernous sinus this thing. So this is how the infection might spread and give you a complications, hell of a complications like cavernous sinus thrombophlebitis. Vestibulitis. This is acute infection of the vestibule of the nose, is called one particular hair follicle or something will be lead to furunculosis of the nose. Diffuse inflammation of the whole nasal skin cavity of the skin, that is leads to entry end of the skin. Nasal vestibule leads to nasal vestibulitis is called, which is usually happens due to chronic inflammation of the nose. You see, etiology is nasal discharge due to chronic rhinitis, sinusitis, allergy. Chronic, usually mostly these are due to chronic situations, trauma, continuous nose pricking and the habit of putting a finger in the nose and taking clearing out this thing, causing clearing out the crusts with a long nailed finger. So these are the most causative organisms. Staph aureus causative organism. There's a staph and staphylococcus mostly. Clinical types. Acute type, red swollen skin of the vestibule and tender. It's a diffuse red swollen skin, and when you are pressing it, you can feel that tenderness. Chronic type, induration of the vestibular skin with fissures and crusting. Yeah, in a chronic type, the whole vestibule, the lower end of the lateral aortic cartilage, if you feel, they won't be so thin. You see, normally this cartilage is so thin, and compared to so thin and supple, unlike the pinna cartilage. Pinna cartilage is more stiff, whereas the lower lateral and upper lateral cartilage are very supple. So, in a chronic inflammation due to chronic rhinitis or chronic sinusitis or chronic continuous discharge in the nose, like some what is that polyposis, some what is that bilateral allergic disease like epidermal polyposis. So, whenever there is a continuous, constant, stagnant secretions in the nasal cavity, a patient might feel that uh, there is something going on in the nose. He constantly irritates, he gets irritated, and he constantly scratches that particular area of the nose. It leads to constant crusting, dryness, constant crusting, fissures, like small creases and fissures over the inside of the tip of the nose, and totally that cartilage gets thickened along with the nasal salute. Particularly the patient is having constantly rubbing the nose like this. This is nasal salute, and particularly the nasal crease will be increased between the lower lateral cartilage and upper bony junction cartilage and bony junction. The crease, nasal crease, will be likely increased. Other signs of allergic rhinitis and chronic inflammation of the nose will be present. This is how you can come to by seeing itself, you can come to a conclusion. Treatment, if it is acute vestibulitis, once again, you can go for just like furunclosis, you can go for normal routine antibiotic treatment and regular cleaning. If it is chronic, like particular crust formation and all, removal of the crust, so local application of antibiotic and steroid cream, uh, and local application of steroids and antibiotic cream. And I feel that saline nasal drops also would help more in clearing that crusts instead of removing the crusts with forceps and all. Rather than if you put a constant saline drops, that crusting will be reduced. Treat the basic cause for this chronic vestibulitis, like chronic sinusitis, chronic allergic rhinitis. These must be attended properly to reduce the basic cause, so that finally you will get an ultimate good result. Because that once the patient is having a chronic vestibulitis, I don't think the picture of his tip of the nose may come down to a normalcy within 10 days, 15 days of time of treatment, as the underlying cause is still present. It needs a long-term steroid sprays and long-term steroid applications to get back to that thin, supple, beautiful tip of the nose. That's a basic modality of treatment we have to follow. So once you have these kind of uh, diseases in the tip of the nose, they might get complicated with this kind of cavernous sinus thrombosis once the infection is very severe, or the infection is being manipulated with fingers and all, where there is a possibility of secondary infection, or when there is a patients are immunocompromised, like HIV patients, the chronic diabetic people. These patients might lead to complications of cavernous sinus thrombophlebitis or sinusitis. It's a serious complication of the disease of the nose and paranasal sinus. It is a really a dreaded complications. I have seen patients, we have lost some patients with immunocompromised state, complicating with chronic sinusitis, and this vestibulitis and facial cellulitis. So communications of the cavernous sinuses. So you have to know what are all the communicating and tributaries are draining venous sinuses that is coming into this thing. So that is the reason why you cannot get confused with actually this chronic when cavernous sinus thrombophlebitis does occur not only due to this facial cellulitis and all, maybe due to other various other conditions also it can happen. So your attention of basic treatment should differ when you know that source of infection or source of infection to that of the cavernous sinus thrombus, cavernous sinus. Anteriorly, superior and inferior ophthalmic veins. So these superior and inferior ophthalmic veins drains. The superior ophthalmic communicates with the angular and frontal vein. Inferior ophthalmic vein communicates with the pterygoid venous plexus. This superior ophthalmic vein communicates with the angular and frontal veins. These veins drain into the anterior part of the nose. That's the basic trick. Because of through this only it drains into the cavernous sinus. Inferior ophthalmic vein communicates with the pterygoid venous plexus. So posteriorly, the superior and inferior petrosal sinus join petrosal sinus. The petrous bone is there, and the petrous bone has got inside of the petrous bone. You have two sinuses, inferior petrous sinus and superior petrosal sinus, joined with the lateral sinus. This lateral sinus obviously turns into the joints. Masculine emissory joins lateral sinus. Inferior petrosal sinus receives labyrinthine vessels. So these are all the potential inflammatory lesion points through which they can drain directly through those drainage veins into the cavernous sinus. Superiorly, it receives meningeal vessels. Simple meningitis also can get causes cavernous sinus thrombosis. Inferiorly, it communicates with the pterygoid plexus. So pterygoid plexus venous thrombophlebitis, like cavernous sinus, like inflammation of post-operative state of inflammation of nasopharyngeal angiofibroma, which the pterygoid venous plexus might get infected and all. So we will deal so much of with pterygoid venous plexus when we do nasopharyngeal angiofibroma. So even inflammation of that particular region in the post-op period also might cause inflammation of the cavernous sinus, finally leads to this thing, cavernous sinus thrombophlebitis. Medially communicates with the opposite cavernous sinus. So this cavernous sinus seems to be draining from the almost all anterior facial skeleton, anterior skull base and lateral skull base. So that is to be carried out point that any skull base lesions with inflammation might lead to a complicated state of cavernous sinus thrombosis. So by mere seeing of the symptoms or symptomatology like cavernous sinus thrombophlebitis, you just don't need to straight away that come to a conclusion that you might be having some amount of infection in the nasal vestibule or dangerous area of the nose itself alone. You have to think about other particular regions where there is a possibilities of infection which might lead to this thing. That is the point of explaining this tributaries or venous drainages, other veins, other sinuses and other veins that drains into the cavernous sinus. So that's, come on, let us slide on to the next slide. Clinical features. I think you must be discussed about this cavernous sinus thrombophlebitis in abrupt onsets of chills and rigors with high-grade fever, vomiting and headache, actually acutely ill, very severe acutely ill, severe pain in the eye, retroorbital pain in the eye, eyelids will be swollen with chemosis as the drainage of the ophthalmic vein and all gets affected. Obviously, there is a inflammation of the eye and congestion of the eyeball and swollen eyelids and proptosis of the eyeball will be there. Third, fourth, and sixth cranial nerves, which are passing through that of the cavernous sinus thrombosis, cavernous sinus beyond laterally, will get affected. Ophthalmoplegia, dilated and fixed pupils will be there. So these are the various clinical features of this thing. Third, oculomotor, trochlear, and fifth is absent nerve, longest possible nerve which passes through the. So this particular nerves which are being affected, the relevant connections of the relevant supply of that particular areas will be affected. So this is how that cavernous sinus thrombosis produces various clinical features. various clinical features, which is a very uh, toxic state of the particular individual. So you please go through the details of this particular symptomatology in your textbooks in a detailed manner, so that you will understand better regarding how the particular cavernous sinus thrombosis will be affecting each and individual particular cranial nerves, and how they particularly finally leads to different symptomatology. Hypoesthesia of the ophthalmic division of the cranial nerve. Yes, ophthalmic division of the trigeminal nerve, fifth cranial nerve. Edema over the mastoid region. Yeah. Diminution of vision, reduced vision. Fundus examination, optic disc shows congestion and edema, as I told you, the basic reason for that and all. So these are the clinical features, various clinical features. So investigation, usually the CSF examination, I don't understand why the CSF examination is to be done here, maybe due to fluid meningitis and all. So CSF examination is normal. So the CT scan of the brain and fundoscopy and blood for culture. These are the main important thing. The blood for culture should be given for to bring out the to bring out the uh, to bring blood for culture, to bring out the what is the basic common source of organism. The fundoscopy to know the seriousness of the uh, fundus congestion and optic disc congestion and all, to prevent uh, from blindness, to treat rigorously. So CT scan of brain obviously will give you a picture of any other sinuses that are other sinuses, venous drainage pathways that are draining other infection sites and all can be ruled out, so that we can confirm to a conclusion. We can come to a conclusion that our nasal vestibulitis or this dangerous area of the face is the source of infection, so that depending on that we might be able to treat better as you are focused in particular region. So the differences between orbital cellulitis and cavernous sinus is one very important thing. We have to know that the orbital cellulitis is the one common complications we see very often in our regular clinical practice, where there is a complicated status of some of the in and around structures of the orbit. So the orbital cellulitis picture is also almost looks like that of the cavernous sinus thrombosis. So that is the reason why we have the basic responsibility to discriminate and differentiate between both orbital cellulitis or cavernous sinus thrombosis, so that we don't fall into a confused state of this or that, and we don't mistreat, and we don't lose the patient finally. So source of infection in orbital cellulitis commonly it. That's what the exact point. You won't be having any external nose inflammation in a orbital cellulitis due to ethmoid sinusitis. So orbital cellulitis is there with the external nose deformity, external nasal infection like furunclosis and dangerous facial edema and all. Definitely, you might think towards cavernous sinus thrombosis, as most sinuses orbit ear or pharynx. So these are the other sinus sites where there is a source of infection might lead to cavernous sinus thrombosis. You can get from nose, you can get from pharynx. As I told you previously, all the draining channels into the cavernous sinus are the resourceful points or sourceful points to that of the infection in the cavernous sinus. Yeah, that's it. Onset. Commonly, ethmoid sinus slow starts with edema of the eyelids near the inner canthus, chemosis, and proptosis. So these are all. It's very slow. It's never a sudden within 2 to 3 days slow arising condition. It's not a condition. It's suddenly arise. There is no acute inflammatory state in the ethmoid sinuses which might lead to cause orbital cellulitis. Orbital cellulitis is also always due to, most commonly due to ethmoid sinus pathology, which is fungal sinusitis. Uh, Most of the fungal cells also, sinusitis also will not cause. Only the invasive type of fungal sinusitis and malignancies in the ethmoid sinuses will lead to orbital cellulitis. Most of the times we have seen, and it's very slow process. It is very slow process. So abrupt with high fever and chills, with signs of toxemia, edema of the eyelids, chemosis, proptosis, and all. So the total picture will be different completely. So in the onset itself, you can come to a conclusion that it is cavernous sinus thrombosis or arterial cellulitis. Right. Cranial nerve involvement involved concurrently with complete ophthalmoplegia. Yeah. Once the orbital cellulitis occurs, the cellular inflammation in and around the orbit leads to complete ophthalmoplegia. Eye cannot be moved totally in matter. So here, involved individually and sequentially, the involvement of the cavernous sinuses. So the nerves, cranial nerves, which are passing through the cavernous sinus, only will get affected, and their reflections will be seen in the orbit, not the local involvement. If at all the local involvement occurs, it will be too very late. So here the situation will be reverse. So laterality often involves one eye. Ophthalmic orbital cellulitis usually involves one eye, whereas cavernous sinus thrombosis involves both eyes, as thrombus of one cavernous sinus might easily can spread down to the cavernous sinus on of the other side. So that is the takeaway point once again. Treatment, as you know, antibiotics, IV broad spectrum antibiotics should be given. With oral treatment, I don't think you can come over with that. Analgesics and anti-inflammatory agents, treatment of source of infection, anticoagulants and anticoagulants. Role is not clear, but use anticoagulants very regularly to destroy the thrombus. Nowadays, heparin and all are used to use previously. Nowadays, that AKT sort of things which we use to give to lyse the thrombus in MIs, myocardial infarctions, also are being given in the most modern treatment setups, these things. I don't know how far they are good, but when you have a cavernous sinus thrombus, which is mainly due to infection, our main focus should be towards the high-grade antibiotics, advanced antibiotics by means of IV and all. So I think in a earlier stages of cavernous sinus thrombosis with good treatment, we may not be able to lose the patient so easily. But once the advanced state occurs, I don't think it's so easy to treat the cavernous sinus thrombosis. Complications of the cavernous sinus thrombosis, as you know, that meningitis and pulmonary infection and death is a grave complication. Review of cavernous sinus thrombophlebitis. Most of the important causes of cavernous sinus thrombosis, dangerous area of the face and nose, orbital cellulitis, sigmoid and sphenoid sinusitis. So the sigmoid sphenoid sinusitis also will not have in a normal this thing. These bony structures are so strong. I don't think they will spread so easily into this thing. They spread through the blood, and mostly the invasive type of fungal sinusitis only will lead to this kind of local destruction and all. So plain orbital cellulitis, almost all these cavernous thrombophlebitis causes are mostly towards the immunocompromised state of patients, not towards the normal routine patient. Normal routine patients, I haven't seen they have ever suffered with this kind of grave complications. Patients presenting with high-grade fever, chills, rigors, pain, and chemosis, proptosis, and ophthalmoplegia, and all those 6 nerves are affecting. So incision, IND, and squeezing of the furuncle of the nose is forbidden. Yeah, that's the thing. Incision and drainage and squeezing of the furuncle of the nose. So if you incise the nose, IND under aseptic conditions, it's a very this thing. You have to have a pre-operative antibiotic cover and post-operative antibiotic cover at least for 7 days. Pre-operatively for at least for 2-3 days. Intra-operatively, you have to take an IV shot while you are doing IND, if at all you plan to do. Squeezing is the main complication for this main worst thing that it spreads the infection through the subcutaneous into the drainage veins into this thing. Squeezing is the worst thing to do. To be differentiated from orbital cellulitis, obviously it should be differentiated, as I told you. Orbital cellulitis presents in a different manner. Complications are serious, meningitis, right? So then comes to the another important disease of the external nose, that is the rhinophyma. Rhinophyma, and I think you should remember our cousin state CM, KCR, and the Telangana CM. So that's the rhinophyma is a enlargement of the nasal tip and the nostrils. It's not exactly the nostrils. Nostrils, in fact, the nostrils might enlarge in some cases. Grave involvement of the tip of the nose, under surface of the tip of the nose. Uh, the nostrils may come to a extenuated state or closed state, but it's not so common. Rhinophyma, the nose will become bigger, tip of the nose will become bigger. It is due to typically acne, that sweat gland disease. There is hyperplasia and fibrosis as sebaceous glands, connective tissues and vessels of the skin. So obviously the sweat glands is getting hypertrophied and they get connected with one another, and local inflammation starts when there is accumulation of sweat and all. So it leads to small minimal inflammation and connective tissue, this thing, fibrosis and all. It's a complex process of mild inflammation of the sebaceous glands to hyperplasia of the sebaceous glands to fibrosis. Finally leads to a potato nose, or this thing. The blood vessels are dilated and the skin is coarse and pitted. Yeah, that's the very important thing. The skin is coarse and pitted. Treatment, shaving of the excessive tissue. The excessive tissue must be shaved. Laser therapy gives good results. I don't know. I haven't seen till now any patient is completely happy with rhinophyma, because it's such a disease. The constant growth of growth and fibrosis of hyperplasia of the remaining surrounding sweat glands is so constant that we never be able to brought back that patient's nose to a normal style. It's not possible. I've never seen a patient is happy with the treatment of rhinophyma. Now comes to the injuries of the nose. Injuries of the nose also comes into a category of the external nasal pyramid diseases. Those are the inflammatory diseases which we have discussed previously. Now the injuries of the nose, many type of the way, in many ways, I think we can get our nose gets injured, as the nose is the most prominent part of the face. That is the ideal. You see, whenever you go for any type of injury in the face, you will be definitely included with your nose, or you will be having a lone nasal injury. Your facial injuries are never without a injury to the nose. Very rarely it happens. Very rarely it happens. So road traffic accidents, sports injuries, personal accidents, war accidents, assaults, and fights. So these are the various types of etiological factors for causing injuries to the nose. So road traffic accidents. Here you see my favorite man, boxing Muhammad Ali. Management, emergency room management. See, for all nasal injuries, there are some basic standard protocols. Emergency room management, airway maintenance by intubation or tracheostomy, hemorrhage. So first thing we have to establish to a particular individual with a injury to the nose. You suspect injury to the whole head and whole body. First thing, any traffic accident. So once you suspect that kind of thing, our primary thing is to protect the airway and preserve the airway. That is the basic means of preserving or protecting a human being. So first, go for a tracheostomy if at all required. Airway maintenance by intubation. If there is a patient is nose is so blocked and mouth is also swollen up and patient not able to breathe through the nose and mouth, you go for a intubation or go for a tracheostomy. If the severe bleeding from the nose occurs by packing and pressure and ligation of the blood vessel ligation and all latter subject, initially you have to pack the nose and apply pressure. Initially pressure, then pack. Associate major injuries to other regions like head, chest, spine, and abdomen, neck, and larynx. So this is the one common thing we do. A patient comes with a road traffic accident with a nasal injury, but unfortunately in our casualty and all, because of lack of knowledge or lack of more work overload, we usually just see the nose and send him off. But see the this thing, the basic primary examination of any traffic accident or any person who got injured by means of any way, you have to palpate him from head to toe. That's the basic modality of injuries. Say because blunt injury abdomens, injuries in the neck, injuries in the chest are may not be seen in the initial stages, but can make out by means of palpation of the chest. I worked as a casualty medical officer for 3 years. Reason why I have been telling, insisting to all my junior doctors and students, any patient who comes with an injury, first basic doctor ga avtarattal manam. That is very very important. So associated major injuries, other reasons like head, chest, spine, and abdomen, neck, and larynx, or soft tissues of the face should be examined. Facial nerve, salivary glands. Yes, injury to the salivary glands and facial nerve. Facial nerve, temporal bone fracture, and all other fractures of the temporal bone might lead to injuries of the facial nerve and salivary glands. So if the salivary glands are injured, there may be possibility of the post-operative or post-traumatic salivary fistulas like parotid gland and submandibular and knife injuries and road traffic injuries where the glands are being exposed to external ears, external outside, or even not exposed to. You have to examine the salivary glands. These have to manage all these kind of pathological. You have to expect this kind of. You have to expect what are the things that these are all the things that can be involved in a traffic accident, and you have to manage in such way. If need is required, you have to coordinate with your other specialty friends and all. So that's one way you have to deal with this thing. This is how you manage. So we come to a bone injuries, divisions of the facial bone injuries. Upper third, above the level of the supraorbital ridge, above the level of the supraorbital ridge. Middle third, between the supraorbital ridge and upper teeth, like the upper gingiva. Lower third, mandible and lower teeth. Mandible and lower teeth. These are the domains, various domains divided for the convenient purpose of like uh, treatment modalities are description wise convenient to each and every one for both the facial-maxillary surgeons and the ENT surgeons and plastic surgeons and dental surgeons to deal with. So suppose the above level of supraorbital ridge is being injured, you can have some sort of injuries to the inside of the brain and all. Middle third between supraorbital region and upper teeth region, you can have injuries to the maxilla and mandible. You can have injuries to the maxilla, nasal cavity, and skull base, anterior skull base, and lateral skull base. Lower third means you have to suspect only mandible and lower teeth and temporomandibular joint injuries and all. So this is how, for the purpose of in better involvement, it was divided this way. Individual involvement of the people, it is divided this way. But whatever it is, when you have one kind of injury, you might have other associated diseases, and you have to deal. You might have to be a come to a situation where you have to deal with multiple specialties. Fractures of the middle third of the face, structures involved. So these fractures of the middle third of the face, structures involved. What are all the structures that are involved? This is what we are concerned with now, because our ENT specialty is mostly concerned with this thing: nasal bones and nasal septum, nasoorbital region, zygoma and zygomatic arch, and orbital floor and maxilla. So these are the injuries we are mainly concerned. Of course, unfortunately, in our post-graduation days, we used to do more of this injuries, but now most of our this region injuries also going towards the what is that facial-maxillary surgeons and plastic surgeons. In fact, they have grabbed from us except for the nasal bones. Even for the nasal bones, the plastic surgery people are doing and the facial-maxillary surgeons are doing. It's a three surgeons domain. It became almost like people, like very less number of people like me are very much interested in this kind of whole head and neck doing this kind of surgeries outside. Many of our ENT surgeons are getting confined to inside of the nasal cavity, inside of the ear cavity only. So reason why most of our plastic surgery and other colleagues take over on all these things. So the structures involved are all these. Fractures of the nasal bones, our basic primary thing, very common injury due to prominent projection of the nose of the face. Yes, that's true. It's a prominent portion of the face. Direct blows or falls. It directly blows or falls. Direct blows from the nose are falling forwards or this thing. So when you have a falling forwards, you will be having almost obviously associated injuries. But in blows, if the blow came to your nose exactly, you might have a isolated nasal bone fracture. That's the reason why in our textbooks, previous textbooks, they used to tell that isolated only nasal bones injury or fracture is most probably 99.99% due to assault. Only nasal bones is being fractured. There is no other injuries of the body. That itself indicates it is 99% is due to assault. And as a part of the facial-maxillary injuries, yeah, often associated with injuries to septum like dislocation, fracture, and buckling, and hematoma formation, and also these are the associated nasal bone injuries associated with nasal bone and other injuries associated with the nasal bones. So prominent projection of the nose. Yeah, that's it. Types, type 1 and type 2. Type 1 and type 2. అయిపోయినా ఇంకొక 5 నిమిషాలు చెప్పేస్తారా వచ్చేస్తారా టైం 1:55 అయింది. ఐ థింక్ ఇట్స్ బెటర్ వి డిస్కస్ ద దిస్ ఫ్రాక్చర్ నాసల్ అయిపోయిందిలేండి సార్. నాకు ఏంటంటే నెక్స్ట్ క్లాస్కి తక్కువ అయిపోతుంది సార్. ఇది మెయిన్ టాపిక్ అనమాట. చెప్పేస్తే కొంత చెప్పగలిగాం. ఇది ఫ్రాక్చర్ అంతా ఇన్ డీటెయిల్ కంటిన్యూస్ గా చెప్తేనే బాగుంటుంది. రైట్ అమ్మా. ఓకే, లీఫోట్స్ అవన్నీ అండి చాలా ఉంటుంది ఇదంతా. మొత్తం నేషనల్ ఫ్రాక్చర్ చెప్పేసి మళ్ళీ వదిలేస్తే వీళ్ళకి మొత్తం అంతా చెప్పాలి. లీఫోట్స్ అంతా కలిపి ఒక క్లాస్ చెప్పాలి. 3 డివిజన్స్ చాలా ఉంటుంది ఇదంతా ఇన్వెస్టిగేషన్. ఓకే ఓకే